Good afternoon. I'd like to welcome everybody to today's Health and Adult Social Care Scrutiny Committee. My name is Jo Lawson and I'm the chair. If the panel could introduce themselves, please.
Councillor Eric Firth, Dewsbury East.
Kim Taylor, Voluntary Co-op Tea.
Councillor Darren O'Donovan, Dewsbury West.
Helen Clare, Voluntary Co-op Tea.
Alison Munro, Kirklees Councillor.
Bill Armour, Councillor of Kirkburn.
Thank you. Sorry, I forgot you, Habibab.
Councillor Habib Zaman, Batley East.
Thank you. And if the speakers that are presenting today would like to introduce themselves as well. Thank you. Yes.
No,
Middle.
Okay. Tally Bastine, I'm the Chief Nursing Officer at Mid Yorkshire Teaching Trust.
Victoria Poskett, Associate Director of Communications at Mid Yorkshire.
Hi, I'm Brent Kilmurray, I'm the Chief Executive at Mid Yorkshire.
Stacey Appleyard, Chief Exec of Health Watch Kirklees and Calderdale.
Thank you. And we've no apologies from panel members, have we? No. He's moving on to the minutes of
Excuse me, Chair. Sorry, it's Vicky Dutchburn, Accountable Officer from Kirklees. I'm online. I couldn't get to the actual meeting.
Thank you. Regarding your request, Vicky, to actually present first, unfortunately, it had been arranged for the team from Mid Yorks, who also have another meeting to attend, so that we will have to keep to the order of the agenda.
Thank you.
And I believe online we've also got Councillor Smage.
Yes, good afternoon.
And moving on to the next item on the agenda, the minutes of the previous meeting. As I wasn't in attendance at that meeting, could somebody confirm that they are a true and correct record?
Well, Chair, I'll move it.
Thank you. Are there any declarations of interest from panel members?
We're all very much interested.
And this is item number 4, admission of the public. This meeting will be held in public and it is being webcast as well. We have no deputations or petitions, and we have no public questions. So if I can then move on to item number 7, which is the Mid Yorks Teaching Hospital Trust strategy on the NH 10-year plan.
Thank you, Councillor Lawson. Is it helpful if I stand or sit? Okay to sit? Right, So thanks very much for the opportunity to come along this afternoon to talk to you about the Mid Yorkshire strategy and some of the kind of key priorities. I'm going to just mention that it's helpful to do this at this point because we're just starting the 150th year of services at Dewsbury Hospital, and it was really great to have some colleagues from the panel come along to the hospital a few weeks ago to do a tour of some of our facilities and to hear a little bit about some of the work we're doing over at Dewsbury. I'm going to just talk briefly about, I guess, some of the national picture, and you probably have heard quite a bit about that already in the past, but also try and very quickly get to a point where that's very relevant to Kirklees and to the services available to local people here and where we're headed with that. You'll, as I say, be very familiar, I'm sure, with the national 10-year plan Fit for the Future. There was obviously a fairly significant engagement exercise that went on nationally to come to a position where there was a 10-year vision for health in England. It covered a range of different facets, right the way from some of the fundamental and founding principles of the NHS about aspects like universal care being free at the point of delivery, but also re-establish some aspects around patient control and thinking very clearly about how we can move forward in terms of moving from a less acute-driven model of care, thinking about a more perhaps neighbourhood-focused, preventative, earlier intervention sort of approach to how we would want to organise ourselves in the future. And particularly an area that I think has piqued our interest and some of the work we're doing around thinking around equality in that and how we can address some of the differential experiences of people from different parts of our community. At the heart of the 10-year plan are three shifts, three significant themes around hospital to community, analogue to digital, and sickness to prevention. As if you bear that in mind as we work through. What we've included within the pack, and I'm not going to dwell too long on it given time pressures, are some examples of how we should see that pan out. And some of that is drawn out in the 10-year plan itself, but actually it manifests itself quite well in our own local plans as well. Thinking about the neighbourhood health service, thinking about the role that community pharmacy can play, how we can, I guess, think about quality of care from a corridor care perspective and restoring our 18-week standard. Big decisions that we're making locally around an investment in a new electronic patient record and thinking about how that will interact with a patient portal in the future, as well as some of the preventative agenda. I've talked about equalities being a key theme for us. The government obviously has laid down quite a legislative framework around things like tobacco control and food advertising standards and various other things. But we'll also start to see aspects like genomics and screening programs, really exciting developments like a partnership we've got with a West Yorkshire company called Pinpoint around cancer screening, and so on start to manifest itself as we come through. I'm not going to talk a lot about this because this is very much Vicky Dutchburn's domain in terms of some of the changes around the operating model, but it matters to providers as well as the ICBs. We'll see some shift in terms of our focus, in terms of integrated health organisations, or as we're sort of stepping towards that, you'll be hearing talk of things like place provider partnerships, and a change in role for organisations like Mid Yorkshire and for Calderdale and Huddersfield Foundation Trust, working in slightly different ways in our local communities. I'm going to move us forward. So just reflecting, I suppose, in terms of Mid Yorkshire, as you know, we are the main secondary healthcare provider in the North Kirklees patch, predominantly out of our Dewsbury site, or Staincliffe as it was used to be known 150 years ago. We are gearing up for a big year in terms of celebration around that anniversary. But actually in the here and now, we're in the middle of a 5-year strategy, which actually, given what's happened with changes to the operating framework and with a national plan, we feel there's probably cause for us to think about pausing that and thinking about maybe a bit of a shift and a reframe of this, and we'd be really, I think, interested in getting your views on that in due course as we progress through that. It's a pretty clear framework that we've set out here. It's about a vision to achieve excellent patient experience each and every time. We've got a set of values that we expect our colleagues to work to in the way that they go about delivering their services and their care, and we've organised ourselves around 5 Ps, and those 5 Ps are population, people, purpose, places and progress, and there's a number of initiatives and projects that, as you'd expect, that would fall from those Ps that allow us to demonstrate how we're moving forward on that. I'm not going to dwell too much on the next few slides, but what I wanted you to hear is that we've given some really serious thought to how we can ensure that, having set out with that strategy, we are prioritising the right sort of work to take that forward. And we've outlined a strategy deployment approach called Improving Together. It's something that's just about a year old. It's embedding in our organisation. It's allowed us to think about how we measure our progress against delivering our strategy, as well as highlighting and picking out some key themes for us to focus on around breakthrough objectives and strategic initiatives. And I'll talk a little bit more about some of that as I progress through. Just moving through to neighbourhood health there. That is obviously a key theme of the community, from hospital to community shift in the national plan. And in Wakefield and elsewhere in West Yorkshire and Bradford and Leeds, we've been identified as national pilot sites for neighbourhood health. But that doesn't mean that the work doesn't happen here in Kirklees whilst we're progressing that. The principles have been set out in a document that was published by the Department of Health and Social Care in 2025, and there are 6 main elements to it that we're working through as a partnership. Primary care is a really strong part of that approach, as you'd imagine, working with the primary care organisations, GPs, pharmacy and so on. But actually, where it's really anchored down is in terms of thinking about those communities, thinking about how we can use all of the various data and information that we've got from a population health perspective to think about what the key priorities should be in terms of focusing there. There's an element of thinking about community health services, and obviously the provider in this area is Lacala. And working with Lacala to think about how we can prioritise investment through West Yorkshire ICB and the Community Care Collaborative at West Yorkshire level to redistribute resources so we can get a standard of provision across community services in the whole of the patch. And that will look at different aspects, if you like, in terms of an analysis that's been done by an outside organisation through that collaborative across the patch to think about areas where we'll need to shore up services to get to that standard. Intermediate care, it's a bit of jargon. It does what it says on the tin in a sense. It sits between secondary and primary care. It's that step up and step down part. Very much community oriented and thinking about independence, reablement, those sorts of things being a really key feature of this model. Multidisciplinary working, not necessarily everyone having the same badge on their lanyard, but actually everyone having the same ethos, if you like, in terms of the provision of services for Kirklees, probably Kirklees neighbourhoods on their lanyard, and thinking about how we are focused around those primary care footprints within those communities to join up provision to think about complex needs, people with long-term conditions, people that have got a range of different determinants of their poor health around social issues, maybe housing, worklessness, poverty, whatever it might be, and think about how we pull together on that. There's quite a bit around primary care itself and general practice, thinking about extending access, particularly thinking about technology as part of that and how we extend the use of the app, but acknowledging that digital is not for everybody, and thinking about how we can address access needs through standard routes that we're all used to currently at a practice level. And think about urgent care as part of that. And that's just another way of describing how we might bring together some of the thinking around neighbourhoods over the next 5 to 10 years and bring together services. As I mentioned, Kirklees isn't one of the pilot sites for this work, but actually, given the bases of pretty good and strong partnership working across the patch, we were able to get a bit of a stride on this work already. There's some clear priorities emerged through the analysis of the data and engagement with key partners around frailty, mental health, and children and young people being the key areas for us to work through there. We're trying to, I guess, do some of the foundational work on this. We've got some pilot sites, which I'll mention in a moment, some early adopters, if you like, but actually starting to pull together some data from the various systems that we have so that we can start to, I guess, join up some of that data and make sure that we, one, are really targeting the right areas. The interventions that we put in place are going to use the evidence base to make the difference, and we can measure the impact that we have on that as we work through that. There is some work already up and running. One site going live in July, a number moving into shadow form during November, with others coming on stream over the course of the rest of this year as we work through. And there's just a bit of further information there, as you can see, in terms of the areas that we've already made some progress there. Excited to be part of the conversation around the Kirklees Partnership Framework, and we had an executive meeting that Michelle was at with us just, I think, last week, where we were starting to think about some of the preliminary work around how we're going to organise the review of that, and clearly everything that we do in this guise and thinking about the provision of care, I guess, from our perspective at Mid-Yorkshire needs to sit within that frame so that we can be consistent and, I guess, coordinated and do our best to sort of progress the integration agenda there. So you can see quite clearly there how that pulls together. So quite a lot going on around neighbourhoods and our place within the Kirklees place. What I wanted to do is to talk just a little bit for a few minutes about, I suppose, our wider role. We're a big organisation. We work across Wakefield and North Kirklees. We employ 10,700 colleagues. We actually bring in an income of about 850 million. About 600 million of that goes into the bank accounts of our employees, most of whom live locally. We also spend a significant sum of money with local businesses. We'd like to do more in that regard. There's also another aspect around our charity work where we are starting to get a better sense of working alongside the voluntary and community sector and other partners across both Wakefield and North Kirklees, and think about the difference that we can make through opportunities around things like volunteering and other aspects around micro recruitment opportunities, training and development, and all sorts of other aspects there. So that's just a bit more about, I suppose, some of the drivers for that. You know, we see that we have a social responsibility, a corporate responsibility, if you like, as well as through our direct provision of services, and it's definitely something that we take a lot more seriously latterly in the last year or so than perhaps we did previously. You know, we're a major contributor to our local economies, and we want to do more with that. This sets out some of the key areas where we think we can do that. I've talked about the economy, our spending power. I've talked about education and employment being a factor there, but also thinking about the estate and the environment. We obviously have a footprint in terms of our assets and estate across the patch. And, you know, there's an opportunity for us to join up and to think more smartly, if that's a phrase, around how we can work with others to make the most of that. And equity and engagement, you know, we need to be reflective of our communities. We need to do more to connect with people within our neighbourhoods if we are going to make these shifts work, and we are going to think about how we can make our services relevant, and we can use our community promise, my community promise, Mid-Yorkshire Community Promise, not my community promise, Mid-Yorkshire Community Promise, to further that there. I'm going to move through the next few slides because I'll be at risk of repeating myself. I think it's possibly just helpful just to dwell for a moment on the place provider partnership. And again, this is, I don't want to step on Vicky Dutchburn's toes because I know that this is a subject that's been discussed before, and she's very much at the heart of some of the work that's going on around the ICB transition, which is driving some of this work. It does fit with the national strategy around that real clear focus on place, thinking about those shifts and how we might make those shifts, thinking about integration in particular and care outside of hospital. We've had some conversations around how we're going to transition through the changes that the Integrated Care Board are currently making. Obviously, Vicky will talk, I'm sure, later about some of the impact in terms of their functions and workforce, which means that others of us in the local health and care economy need to do different things in different ways to address some of those issues. One of the things that you'll be aware of is that the Calderdale, Kirklees and Wakefield places will be more integrated from a management perspective under the new ICB arrangements. And that's given us some opportunities to come together. We had done previously, but it's given us new impetus to come together to think about how we might share some of those responsibilities across that patch. And particularly from a place provider partnership point of view, the clues in the title, we're looking for providers to take a greater role in coordinating, I guess, the planning as well as the delivery of services. And from that point of view, we've had conversations with NHS providers in the areas, with Calderdale and Huddersfield, taking a leading role within the Calderdale patch, with Mid Yorkshire taking a leading role within the Wakefield patch, and in this patch, South West Yorkshire Partnership Trust playing a greater role there. There's quite a lot of work involved in that. There's significant monies involved and tied up in it, so you can imagine we need the right governance, the right arrangements, as well as contracts and various other things. And that's the work that we're currently doing, is to get the right framework in place, having identified the key priorities to allow us to work that through. I'm going to ask my colleague Talib Yazeen to step in for the next couple of slides, because I think we were asked in the conversations that we had when you came to visit us a few weeks ago, just to spend a little bit of time focusing on some of our quality issues, and then I'm going to finish off, Chair, if I may, with an eye on the clock, talking about some of the services currently in Dewsbury and some of the impacts, I guess, of some of the activity that we've seen coming through lately.
Press the button. Yes, thank you for the invitation. And some colleagues who visited the hospital, we spent some time in the new surgical hub. We went to our emergency department and we went to our Bronte Birth Centre. So some of the work we're doing on, obviously the number of patients that come through into emergency department or need admission isn't fundamentally in our control. Sometimes that means we end up with more patients than we've got technically bed spaces for. We have a process for managing that, we have a process for risk assessing that, and we have a process for apologising when that has to happen. So they get a letter from me, the Chief Medical Officer, and from Brent, saying it's not where we want to be, but we're having to take these steps because there's literally more patients than we've got space for. We've worked with Care Quality Commission on that, and I'm thankful. I think the day colleagues came, it was busy in the emergency department at Dewsbury, but it wasn't massively overcrowded and things were under control and well managed. And we've had fairly significant pressures, probably since Boxing Day. Post that New Year, Christmas, New Year, we've had a significant number of patients in. Thankfully, flu hasn't been the biggest challenge. I think it's been everything else, chest infections, cardiac, general illness. Flu hasn't been the thing that's tipped us over the edge. Those pressures we anticipate will probably carry on for the next few months, but we're doing everything we can to get out of using those temporary escalation spaces or caring for people in corridors, because it's not a great experience. Even though many patients say to us, look, everything's great, I'm getting what I need, you're communicating with me, but still, it's not what we feel is the right thing to do, and we try our best to make sure we risk assess people. And CQC, when they come and visit us next in February, we have regular on-site visits. We have visits from our ICB colleagues who come around and, independently walk around, talk to patients, walk the wards, walk services. Our next visit with CQC in February, we'll be talking about urgent and emergency care and some of the plans we've put in place to improve things and try and systematically make a difference. And a broader piece of work which the Trust is leading is looking at the clinical service model. We've seen population growth, thankfully we've seen inward investment. So we need to make sure our model across our hospitals and our community is now fit for purpose going forward. I think we're fairly hopeful that'll help us shape what we do in Dewsbury, what we do in Wakefield, what we do in Pontefract and elsewhere going forward. So covered quite a bit of information in there, and thanks for colleagues who came to the visit because they raised quite a few issues about Dewsbury specifically. So we've included information in the pack to sort of demonstrate it's a busy place. We're not interested in it not being a busy place. And I think hopefully from the visit and from the time we spent together, you've got a sense of that and you've got a chance to meet and talk to staff independently. So it's a constant curation of quality and safety. That doesn't go away. Every day we're on that. It has its challenges, but I think we're trying to do that transparently and openly, and we're facing up to the challenges that we find. So, but happy to take any questions. I'll hand back to Brent.
Yeah, and just to finish off, and thanks for that, Talib, but just to finish off, we have included within the pack some information about the range of services that we offer out of Dewsbury side, and we've also put some numbers against that. You can see that post the acute hospital review in 2017, we've been able to show, I suppose, how that shifted. I suppose one thing to say is that we are doing a big review currently, as you can imagine, in a big trust like ours operating across multiple sites. Whilst we're trying to obviously make sure that we've got some of the things you'd expect to see in every district hospital if you like, in each of our places. There's an opportunity for us to think about how we can specialise some of our areas or use some of our assets in particular ways to make sure we can get the right concentration of skills and expertise, as well as investment in equipment and various other things. So, for example, the surgical hub that you all came to see is a facility for the whole trust, for the whole patch, as well as, I guess, some of the things that are very local, like the A&E department that you visited and so on. So we're constantly, I guess, thinking about that blend and that mix, thinking about the impact that has on our local communities, and we're going to be doing a big review where we'll fundamentally get underneath the data, and as part of the place provider partnership, we'll have an opportunity to think about what's the model for Kirklees across the patch, given the north of Kirklees and the south of Kirklees are currently covered by different providers. Lacala kind of joining it up in the middle. We'll have an opportunity to take a step back and think about what that looks like across the entirety. I'm going to stop there because I know there's a lot of information in the pack and I didn't intend to go through it blow by blow, but I'm sure people will have questions.
Thank you for the presentation and the insight that you've actually given us. If I can just go back to the emergency department, it's a type 1 emergency department. Could you just elaborate on what would be seen at Dewsbury, what might have to go to Pinderfields?
Are you able to cover that clinically?
Yeah, so we've already got a model in place, so we don't, apart from admitting acute care of the elderly patients, if somebody was having a heart attack and arrived at Dewsbury, we'd stabilise them and transfer them to Pinderfields. So it is a type 1 emergency department, so is Pinderfields, but Pinderfields deals with a more complex range of services because that's where we've got our most complex, so our stroke hub is there for thrombolysis. Our emergency surgical work takes place there. So we treat and transfer and hopefully discharge as many patients as possible from Dewsbury. And our ambulance service colleagues, we didn't put it in the pack, but you'll know there's an ambulance hub on the Dewsbury site. So that allows vehicles to be, easily accessible to the population. They already know, for example, if somebody phoned and said, this person, I think my husband, my partner's having a heart attack, they would take them to Pinderfields versus Dewsbury, so that helps manage some of the workflow. And our children's assessment unit closes at 10 o'clock at night, heavily used by local population. And certainly in probably another hour or so, when schools come out, you'll see an influx of patients and children. And when I think colleagues visited, it was in the morning, so it was probably a particularly good time. And we did say, if you came back in 3 hours, it's probably going to be a lot busier. But again, a really good team, consultants, nurses, paramedics. We also have the walk-in service at Dewsbury. So again, it deals with a really mixed client base. So, and part of the clinical service review will look at all of that to say, have we got the model right? Do we need to do things differently? But good department, well organised with good staffing, and always more to do though. The standards go up, I think, every year, the challenge goes up. And if we stay static, we'll be falling behind.
Thank you. I'll open it up to the panel. Councillor Firth.
Thank you. And by the way, colleagues, thank you again for the welcome and when we visited you, with our team. It was most illuminating, but in a good way. I have several questions, by the way, Talib. You mentioned corridor care. Have you any spare capacity or plans to build in more capacity, beds, new wards?
I think some of that will probably come out of the clinical service review. Are we using all of our assets and capacity well? Could we do things differently? I think that'll be one thing. The second thing is, it's not always about more capacity. It's about, I think, whether we're using the capacity we've got now well. Are we assessing and treating people quickly enough and then discharging them soon enough? Hospitals are challenging places. You can catch things in a hospital you didn't have when you came in. So if we don't need to admit you, how do we get you into an ambulatory outpatient pathway where we can do your assessment, we can do your investigations, and we can give you the treatment quickly? So we're just about to embark on some work to look at how we improve the flow through our hospitals. And there isn't one magic bullet, but if you imagine floors are, you know, like a snake from one end to the other, if we don't pay attention to all the segments all the way along, so are patients able to leave our hospital easily? Are they able to enter easily? And then are we able to make the right decisions at all parts? You get stasis and things to slow down. So we definitely need to work with Kirklees social services and Wakefield social services on more rapid access to services. And I know that's challenging, you know, domiciliary care, care homes, complex needs, reablement. But sometimes patients are waiting for that, you know, for a period of time and they really need to go out. That can block us up a little bit. Equally, if we admit patients who don't need admitting, it takes up a space others might need. So we've got some really active plans around same-day emergency care. We're expanding that to try and attend to that. So I don't think the answer is necessarily more beds at this stage, but it'll be informed by the service review. But we need to make sure that all the best practice around flow, assessing people quickly, making decisions, letting them know what the plan is, happens for every patient. And I think we've more to do in that space. You know, we're a big organisation on 3 sites. And there's always human factors that come into play. But I think our staff are committed to doing that because it's not great experience for staff, families or patients if we don't get that right. So I think we've got a challenge to do everything we can in that space.
Councillor Firth.
Thank you for that, but we all know, we're all aware, not just at the Mid-Yorkshire, that national scandals about people being on a trolley in a corridor for 15 hours and passing away in corridors, and we all know the impact that has on families and your staff as well. And so I'm glad that is being looked at. Can I just have another question developing that a little bit? In your presentation, you talk about healthy care, about men and women in the 60s. There's a decline in the health, according to the stats. And the life expectancy of people in certain parts of North Kirklees is worse or less than other areas. Does this part and parcel of your provider partnership model looking into on population health planning responsibilities, does that all follow in that?
I'll go first, didn't you? Yes. I mean, short answer is yes. But I suppose there's probably lots of different levels and layers to it. I think that health inequalities has always been a key feature of the narrative and the priorities for West Yorkshire, but I think it's come much more to the fore in terms of certainly some of the dialogue that we're having within an organisation like ours. So Talib actually is chairing a group of colleagues with public health involvement to think about how we can better differentiate what we do on a day-to-day basis to make sure that we can get care to people that need it from a variety of different backgrounds who have previously experienced barriers to that. Absolutely, from a place provider partnership point of view, health inequalities and making sure that we've got that sort of approach is going to be embedded in what we're doing, and it's certainly something that I think, you know, we'll be held to account for as we work through that.
And just to add, I think part of the opportunity of the place partnerships is about how do we keep people well as they can be relevant to their physical health and prevent deterioration, because often by the time people have deteriorated, you know, they probably do need an ED then, but if we'd have intervened earlier, could we have prevented that? And again, for people, frail elderly with multiple conditions, a really busy ED isn't necessarily always the right place. So again, what other models can we offer that will allow those people to be assessed and treated without being in a busy ED? So I think there's lots for us to go at, but that maintaining wellness, like I'd love to run a 2-hour marathon, and even though I'm relatively fit and well, it's not likely. So we need to be realistic about, again, what is it that matters to the patient and the family about their level of health that keeps them at home preferably, or in their place of residence, because that's where most of us want to be. If I'm not well, I want to be at home in my own bed. I don't really want to be in a hospital as much as I work in one. And I think that's got to be our aim, and that's about being responsive. If we take 2 days to respond to somebody who says, I don't feel so well, they're probably going to end up in the ED. And that's not what we want. So I think that's where place partnerships, working with voluntary community social sector, local authority colleagues, reablement, gives us a real opportunity. But we need to be responsive. And if it's, well, you'll have to wait 2 days, it can be too late. So I think that's one of our great challenges, but it's an opportunity as well.
Thank you, Kim.
Hi, again, thank you for a really informative visit a couple of weeks ago, really enjoyed it. A couple of questions from me, different themes really. I wondered if somebody could explain the difference between the integrated neighbourhood teams and the primary care networks, and how do the community services fit into that? So, for example, from what I understand, there are kind of discrete differences, but how would, say, district nursing, community nursing fit into these networks to slimline the patient journey, to make it more joined up? And the second question is around the Bronte Birth Centre. Fantastic facility, but I see from your presentation that you're intending to review it, of course. What are the criteria? And I'm just wondering, is there kind of a utilisation? Is there a number that you're looking to achieve, or maybe not underachieve, whereby you may think, we need to maybe look at this because we're not getting so many births through? Is there any risk in that at all? Thank you.
If I could pick the first one, and if I hand over to you for the second one, Talibah, I am conscious that colleagues are waiting to come on. So, in terms of the integrated neighbourhood teams and the PCNs and I guess the interface with community, primary care networks obviously is something that it's a mechanism for a number of different things. Obviously it's a contractual mechanism, but it's also a way of bringing together practices, usually in a particular geography, to come together to think about how they can provide enhanced services in a variety of different aspects, but particularly from a primary care perspective. Sometimes that'll involve things like social prescribing and other things, but it's very much focused on that lens. There. The integrated neighbourhood team approach really is thinking broader about those geographic areas, the populations that live there, and trying to think about how we can bring other services like community nursing teams or palliative care, end-of-life services, perhaps the outreach from the hospice, the VCSE, debt and welfare advice, employability, all around the kind of same area to work in that multidisciplinary sense. Okay. And that's the distinction for me, in a nutshell, is how we can take the opportunity to take a step back, look at the data, think about what the needs are, think about what the barriers then are, and then get all the right people in that approach. And then the skill is about that coordination. And there's an opportunity for us to think then more about potentially new sorts of roles, care coordination roles. We already have some of those on our community services in Wakefield, where they are joining the dots for individual, particularly complex patients. But, there's a chance for us to think about different sorts of ways of working as part of that. I'll hand over to Tally for the...
Yeah, just quickly on the Bronte Birth Centre. So that's a standalone birth centre at Dewsbury Hospital. We have an alongside birth unit at Pinderfields, and we have a full obstetric unit there, and we have home births right across the patch. So the review, I think, is to say, are we doing it well? Other lessons to be learned. And we had very much a soft launch when we reopened in April 24. Seems ages ago, but it's not really that far. But I think when we came, what we also emphasised, and I think Kay did when she spoke to you, is it's a hub for women and families. It's not just about how many births take place there, but it's also a convenient place for people to come in for review with community midwives as well as deliver there. And we had a fairly slow start, but we're motoring up now. And I don't think we have a line in the sand about, well, if it's not this number, we must close it. That's not, I think, what we think is relevant. It's that access to the opportunity. And we know, like with yourselves, once you get people into the birth unit and they can see the quality of it and talk to the staff, they really see it as a real opportunity. There's still a lot of myths around with Bronte Birth Centre about what might have happened 20 years ago and so on. So it's getting people through the door, letting them see what's available. And it's not for everyone because it's criteria-based, so it's low-risk deliveries. Yeah. And we have transferred women from the birth centre back to Pinderfields because there have been changes in the condition, and that's all worked well. We work with Yaz. And the team are brilliant. So we want to develop that hub concept. It's a beautiful space. It's a great, and you'll see the comms team, I think every Thursday we usually put somebody out who's delivered a baby at the Bronte Birth Centre. Yeah. I try to like all of them every Thursday. So I think when the word gets out, So it really, you know, and people are looking at those birth centre options well beyond the Kirklees population, and we're open to that. So it's the opportunity. I'd love to say, you know, we're absolutely bursting at the seams and we can't fit any more women in. That's not the case currently. It'd be nice to have that as a problem, but we don't. It's not a problem yet, and I don't think the finance of the centre is our only issue in reviewing it. And it's not, you know, it's not clear. Well, it's not making enough money. We must close it. And it's a fully open model, so we don't have an open and close. We have an open model all the time, because if you have the open and close model, it's easy to kind of close it and not reopen it. So we committed to an open model, and so far, that's worked successfully. And we've got midwives who've specifically come to work with us because they want to work in a birth centre. You know, I won't say low tech, but low intervention delivery. And that's what they're committed to. So it's an attractive place for people to come and work. And if any other colleagues want to come and see, we'd be delighted. And any help you can provide to promote it, we'd
Really
love that.
reassuring, thank you.
Yeah. Well,
Just two quick additional points on that. I mean, the review isn't a threat or driven by anything other than it's just good practice, isn't it, once we've made these changes to come back and
of course.
see how it's working. And I'd absolutely endorse what Talib said. There's no magic number there, that, I guess, in terms of the threshold, because it performs a number of different functions. But we would like to see it grow, so your support, I think, would be really welcome.
Thank you for that clarification, because when I saw under reviewing the success, I was like, I can also confirm that I have seen a lot of social media posts about the Bonte is flagging it up, that it is actually there as well. But thank you for the clarification. Helen.
Hi, my thanks as well on the visit. It was really informative, really interesting and really engaging. Thank you. Just sort of looking at the whole sort of like the 10-year plan and all the rest of it. Could you just tell us what the what you identified as kind of like the risks of it, the threats, the challenges, what's going to get left behind, or what's going to be, because it is all very positive and I can see the way forward. It was just to get the whole picture of what do you see as the main sort of issues. Thank you.
If I can, just in a nutshell, I suppose that there are a few things. I suppose this is a massive change process, isn't it? We've got to engage the local population to think differently about where they come for their care. The fact that we want to get that hospital to community shift implies, I think, we've got to communicate well with people so they understand where they go for what. So that's a key thing for us. There's an element of engagement with our workforce, so we're used to working behind the walls of a hospital and getting them used to the idea that they may not in the future, and thinking about different sorts of approaches, whether that be through digital channels or in different settings. There's then, I guess, some of the investment that's needed to support some of those aspects, whether that's investment in those digital channels or thinking about different sorts of estate that we might require, or equipment. So there are a number of, I guess, practicalities that we need to think through, that obviously any kind of shift, transformation, if we can use that word, you know, often requires, doesn't it, the ability for us to grease the wheels of that through investment and move it through. Some of it won't take much. Some of it we can, you know, do pretty quickly by just repurposing things or perhaps relocating them or whatever it might be. But some of it, I think, will require some, you know, big sort of conversations and thinking really around that sort of approach. So I see them as probably the key things.
And would you see that there was a mention of pharmacy and sort of expanding their role, or how much people use them, and yet we've heard on the other side of that pharmacists are saying they just can't do anymore. And so that was a bit of a concern for me, that it sounds great to be doing, but are these sort of key people actually set up to do more, essentially, is what we're going to be asking them to do.
So there's all different parts of that multidisciplinary team, and I think obviously the national plans put forward community pharmacy in particular has been a key opportunity there. There's a lot of work, I think, to be done on that. I'm not even going to mention dentistry, but you know, from an ICB perspective, you know, they will be looking at some of the new forms of contracts that are going to be coming out and thinking about the commissioning opportunities around that, what that's going to mean in terms of then the local partner provision. But I think what we're identifying, or what has been picked out of that plan, is a real opportunity for us to do that, thinking differently about where people come. you know, where it works well, it works really well for people. And, you know, I think the opportunity is to think about how we can get that variation ironed out and, you know, think about locally getting more of it in the right places through these national moves that I'll need to make.
Councillor Zaman.
Thank you for a comprehensive presentation on your 10-year plan. You talked about the key pillars on one of the slides around sickness and prevention. I'd like to highlight concerns and evidence consistently that's been demonstrating, particularly within our sort of local communities, that men of Pakistani and wider South Asian heritage experience significantly higher rates of premature cardiovascular diseases, frequently presenting in their 30s and 40s and experiencing poorer outcomes than the general population. Given that this has been talked about and it seems to be quite a high risk within our local communities, what targeted prevention, screening and early intervention programs are currently in place locally for high-risk South Asian men, particularly in relation to diabetes, hypertension and cardiovascular disease? Is there any services uptake and health outcomes routinely monitored by ethnicity and gender? And if so, what is the local data indicating for Pakistani men, particularly under the age of 50? How are commissioners ensuring that health inequalities are being addressed proactively, rather than relying solely on population-wide approaches and evidence, particularly within this group, suggests that there is insufficient services that are preventing these deaths? And if these gaps are identified, what specific actions and timescales can we expect that will be put in place to reduce preventable early deaths within this community?
Thank you for the question, and it does touch on a number of themes that we've already covered. So I think if I just refer you back to what Talib said earlier about health inequalities in particular and some of the conversations and the work that we've been doing on that. It does relate, of course, to some of the things that we talked about earlier in the presentation about thinking about population health data and how we can differentiate what we do for particular parts of our communities to work through. I definitely see in this area that primary care has a significant role to play in this in terms of that early identification and the opportunity to case find and to capture people early on in the onset of their disease and work things through. I think from a mid-Yorkshire perspective, we would very much want to work through the place provider partnerships to think very clearly about how we can, support that by bringing the expertise out of the Walsall Hospital, as I've described, and actually into the community, whether that be through specialist nursing roles in the future or outreach consultant level sort of positions. It's very much the sort of thing that I think that we should see emerging through this new way of working. And I think it is acknowledged, what you've described, and I think it should be a priority in the work that we do.
And Chair, just I can't answer all of what you've asked today, because that was a great question, by the way. But what we'll have to do is take some away. So, for example, I know one of our senior diabetic consultants runs a clinic on a Friday. We have cardiology clinics. We have a respiratory function centre there. We're also working with different ethnic groups in communities, because we know some people don't necessarily trust public services, and so sometimes there's a hesitancy in coming forward, which then leads to an inequality. So there's more to do, but what I will do is take that away and speak to both our diabetes and cardiology teams and see what's in place. So we also have cardiac rehab across our patch, which is highly successful and won awards for, but I haven't got all the detail with me, but I'll take it away and specifically think about Kirklees and come back with an answer, if that's okay.
Thank you, I'd appreciate that.
Yeah, good question, thank you.
Councillor Munro.
Thank you very much, Chair. So, first of all, I'd just like to apologise for not being able to come to the to your hospital recently. Unfortunately, it was due to the fact that I'd had to wait 5 weeks for a doctor's appointment, and I could not miss it. And it was in response to some blood tests that I don't mind telling people that. So I thought 5 weeks was somewhat excessive, but I needed to. So anyway, so that's why I was unable to come. So I just thought I'd say that because this leads me on to your key pillars. And one of those is same-day GP appointments online first. So I'd like to know how that works because I wasn't allowed to make a same-day appointment.
So just to clarify, that's the national plan.
Right.
Clearly, we're here from Mid-Yorkshire Hospital, so we don't provide GP services or commission them. So it may be one that we can ask Vicky to pick up or take away and come back with.
Okay.
But I think we would acknowledge that there is some stretch and challenge in this, and we'd love for you to rearrange to come back and see what we're doing at Dewsbury. But in the meantime, I probably would refer you to the ICB on that one. It's not an area that we cover from a provision perspective. I was trying to set the context in terms of some of the work that we're doing, but I would absolutely acknowledge the challenge that you've had and hope that we can work with colleagues in the future.
Right, thank you. So can we move on to my next question? Chair? Okay, so this again is really probably a national thing in relation to genomics. It's going to be the 10-year plan is genomics driven. So I just wanted to know how that relates to the work that you're doing here in across our area and what impact that's going to have. Does that mean that we'll all have better access to health services, for example?
I think that's the ambition. It is a national statement, you know, and I think one of the underlying principles that I mentioned is about personalisation of care, you know, and ideas like genomics and how we use DNA and all those sorts of things, you know, will probably be later on in the 10-year plan. But there obviously are some great examples already around, you know, very leading, say, for example, cancer treatments that certain centres, just over in Manchester, for example, you know, are already kind of leading the way on developing those sorts of very personalised sort of treatments for particular disease groups. So it's definitely, I think, a very exciting proposition for us going forward. But early days in Mid-Yorkshire, but certainly there are examples around the NHS where that's really making a difference already. Well, I think at this stage we've used probably a wider range of different population health and other demographic information to support that. You could perhaps see in the future, you know, I'm talking a long way, maybe even beyond the 10-year plan, where, you know, that very, very personalised sort of data could be used, sort of aggregated to sort of, I guess, drive some of that thinking. But I think that's a way off yet.
These changes will improve access to medical health operations, etc., specialists in a more timely manner. You know, what can you say? I mean, how do you you know, can you assure us that this is going to all work? I mean, we've talked about risks. I mean, you know, there must be some areas that you're perhaps uncertain of, or.
Obviously, you've mentioned the risks. You know, I've covered that in the previous question. I suppose the real opportunity around some of these shifts is to think about, I suppose, the specific roles that some of our current areas of, or centres, if you like, or facilities will actually focus on. So Talib described earlier when we were talking about the corridor care and some of the pressures, I guess some of the aspects of demand that comes through our door, which is fairly undifferentiated once it arrives. Because it's where the community knows that they can come and they can see someone and be treated. The opportunity around the treatment to prevention is very much for them to access the majority of what they need more locally, which will mean that trusts like us and services like ours can really think about our capacity in a different way and think about how we can, I suppose, widen what we're offering to make sure that we've got sufficient of it to meet need in a more timely way. So I think there's a real sense of hope, really, that that's where we're going to land with it. I think there's a journey to go on to get there. But that's the theory that I guess supports that, and I think we're in the early stages of taking those practical steps.
Thank you very much. And I wish you every success with it. Thank you.
Thank you. Are there any further questions from the panel? If not, I'd like to invite Councillor Smage, who's online.
Thank you so much for allowing me a question. Can I just say my apologies also for not attending the look round Dewsbury. I had a mayoral appointment on that day. Can I just quickly mention about the review of the clinical service reconfiguration model? I can remember at the time there was a lot of discussion about outpatient appointments and people having to travel to Pinderfields for outpatient appointments and people from Wakefield having to travel to Dewsbury. And I noticed from your figures that there are low numbers for outpatient appointments at Dewsbury. And I wondered if that could be looked at from the assurances that were given at that time about outpatient appointments and how that's working now. And your review of the Bronte Birth Centre, I just wondered if you could include, we'd heard previously that there'll be more work with CHFT, and I would be interested to see how, in your review, that work is progressing. But my main question is, there were some phrases used, clinical services review, redistributing provision, standardising provision, working with Locala, reimagining the model across Kirklees. And I'd like to understand what in real terms that actually means, please.
So I'll just deal with the Bronte Birth Centre point first. I don't envisage that really being specifically, I guess, focusing on the relationship with CHFT at this stage. It'll be very much a revisiting of the plan that we put in place for that unit. Clearly, we will have further conversations through that partnership lens around some of our broader clinical pathways, and at some point maybe maternity will sit as part of that. There. I don't know whether you'd add anything on that.
And the only thing I would add is any woman who wants to birth in the birthing centre, irrespective of where they are in Kirklees, we'd welcome them. I mean, I realise it's not a hop, skip and a jump to Dewsbury from like the middle of Huddersfield, so it's about what works for individuals and families, but that offer's there, so we're encouraging with CHFT to make sure that the birth centre is seen as an option for local people, because, you may choose to book here, and then you might say, well, there are different options. So we're trying to encourage that as much as we can.
I suppose in terms of the first part of your question, the starting point for our clinical services review will be to revisit the piece of work that was done in 2017, where we looked at the different opportunities around the distribution, if you like, of services across the three acute hospital sites, and to think about, I suppose, how that has worked. And to what extent that has benefits and to what extent that's caused problems, and certainly to think about what that means for our communities. And the work that we've done has really clearly set out that we want to do quite a bit of engagement work with local communities as well as clinicians and partners as part of that, to get perspectives on what that looks like. The points about working across Kirklees, I think pretty much what I said earlier, place provider partnerships, the neighbourhood health model does give us an opportunity to think very differently about where things sit, frankly, and the connections and the joined upness between what we do, and that's the challenge there. So at the moment, there are organisational and geographic and all sorts of other, I guess, barriers that come into place between the way that we, electronic systems and so on, workforce challenges, that come in the way of perhaps us being as joined up as we would want to be. So from that perspective, that's what's meant by some of those words that were quoted there. So that gives us an opportunity to rethink the way that we do things, the way that we focus services at a neighbourhood level. I think through those 6 pillars that were set out in the presentation, allow us to think about more of a consistent approach across Kirklees, but actually what we've said about health inequalities and the use of data might mean that we get different things delivered in different ways in different places to meet the specific needs of those different communities. And I think we've got to get comfortable with that as we work through that. So I think, I'm not sure whether I've addressed your question. I think there's probably more of a conversation there than maybe a question and an answer. But I'll be very much welcome to have that discussion with you. And just to reiterate, the colleagues that couldn't come to visit us, you're very welcome anytime, and I'll be more than happy to facilitate another round of visits if you want to do that.
Thank you for your answer. No, you not quite answered it, but I can appreciate why you've possibly not quite answered it. I've been involved in health scrutiny for a long time, and certainly was involved in scrutinising in 2017. So I do think that scrutiny ought to have more involvement. Obviously, that's for the panel to say, but have more involvement in your reconfiguration model review. And also, I think it would be good if scrutiny could also have early discussions about what you mean about this service provision across Kirklees, because yeah, my experience tells me that that needs scrutiny to have involvement at an early stage. Thank you.
Thank you, Councillor Smage. If there's no further questions from the panel, I'd like to first of all thank the team.
Sorry, just picking up on what Councillor Mays just said about the opportunity to have some to be involved in the review. Is that something that you would consider, and is that something that we could ask, and that, you know, for the panel to be involved in?
Yeah, I mean, yes.
As part of the summing up that I was about to give, I have actually suggested that they do return to us, and obviously we would want oversight of any configuration work that was going on, and if services were to move out of the North Kirklees patch into Wakefield or vice versa there. So I'd like to thank the team for their very comprehensive presentation and oversight into the work of Mid Yorkshire Trust. We note that the NHS landscape is undergoing many changes in the present time, and that Mid Yorkshire is not only working to improve the services that they provide, but is working with but as an anchor organisation is working with other organisations to provide and improve services for the community. We also note the work and range of services provided by the Trust at Dewsbury District Hospital, seen in this report and on a recent visit to the hospital. We welcome further information about health inequalities in diabetic and cardiac services, and the work being done to address this being given to the committee at a later date. It would obviously be prudent to invite you back to a further scrutiny committee to look at the work that you're doing, not only the work that you're actually doing and the ambitions that you have in future, but obviously any potential reconfigurations of our services. And thank you.
Thank you.
Thank you. If we can then move on to agenda item 8, which is changes relating to the NHS England and the integrated care bodies, and then we'll have a presentation afterwards from Health Watch. Vicky, we understand that you may have to leave, and I'm just concerned that we might not have the time to actually ask all the questions that we've actually got.
Chair, I've actually sent apologies to my finance meeting with the Exec Director of West Yorkshire and asked them to rearrange the meeting.
Thank you, that's much appreciated. If you'd like to give your presentation then.
Okay, so the presentation has been circulated and I believe it's in the pack and went out for everybody to be able to see it. So I'll go through the presentation quite quickly so we've got the opportunity for questions. What you will see on slide 2 of your pack is the key questions that you raised to be addressed. On slide 3, what we've done here, what I've attempted to do here is just try to set some of the context of the future health and care landscape for people to see. So what we do know is that it's a major significant reorganisation, as you say, Chair, of health services or health commissioning services, which expands not only from NHS England, DHSC, but also into the regional and then into the local integrated care boards. What we do know is there are 4 moving parts to this as we see it, as I've laid out on this, I think, pyramid. And what I would like to say within this is that we are only one part of those moving parts. They're not all moving at the same time. They're not all moving at the same pace. And I think there is potential that will be going backwards on some of this as more information comes out. So we're always working with the best information we have available at the time. So nationally, they're looking at their reorganisation as NHS England and the DHSC. They've only just recently confirmed their actual timescales, which are at the end of this next financial year, so that's 27-28. To do their full reconfiguration, reduce their workforce, etc. In doing that, they are starting to now set their scope and their blueprints for what they will be delivering. But as I come further through my presentation, I will keep reinforcing that the work that we've had to do as the local ICBs and West Yorkshire ICB has had to be predicated on the best information we've had available. The regional teams are working to a similar timescale, but as yet have not got their full blueprints ready to say what services they will be taking. And as a consequence of that, what we are seeing at a West Yorkshire level is that certainly for this next 12 months, we are still being told there are some elements that we will have to deliver while the regional teams get established. So an example of that, just picking up from the last presentation we had, is around primary care services, which are nationally contracted with the GPs. Back in March, when we got the blueprint for the ICB, it had very little included about primary care provision and certainly nothing about the core services that they are nationally asked to commission. What we got 2 weeks ago is that we will still have some oversight of the core service provision. So we are having, as West Yorkshire, to review the structures that we've currently got out to consultation on that fact, because we've recognised we're going to have to strengthen the structure that we're proposing and the workforce in there. What we do know and what we've been given a very clear mandate about is that the local, as in the West Yorkshire and the Place ICB functions, are going to be around strategic commissioning to improve the health, population health management and reduce inequalities, and to the best of our abilities ensure we've got consistently high quality and efficient care for people in our populations. And in doing that, some of that work will be delivered by our providers. It will be delivered at neighbourhood level. So as Brent has just discussed in the Mid-Yorks presentation, there is a lot of collaboration and partnership working across our providers, including primary care, community, our mental health services, our VCSE, etc., to start developing what some of those pathways will look like. The first phase of all that work is looking at the services we already deliver out of hospital in communities, making sure we get those as efficient and as streamlined as possible across those partners. But we are already looking to the future and what are the services that we would like our future provider collaboratives to develop in the way of what we call left shift. So that is the potential services that will move out of our acute hospitals into our neighbourhoods or community settings, because that is the best place to be able to do it. Whether that is bringing specialists, as in consultants, etc., out of the hospital to be able to do that, or if there are other innovative ways to be able to move forward. What I then showed in the pack is just a brief cycle of what strategic commissioning is, which plays back to what I've just said. That's about us understanding our local populations, assessing the needs, developing those long-term population strategies and plans, then working with providers to ensure the delivery of that. And as a strategic commissioner, it's about setting the contracts at the right levels, making sure we've got the right risk gain shares, the right risk and gain share opportunities highlighted in those contracts, so that we can move fleet of foot, but we can also move the money around the system, because the Kirklees pound is the Kirklees pound, and once you've spent it, it becomes difficult to spend again. And then obviously it's the evaluation of the impact of that, both on the day-to-day usage of our services and how our population choose to use them, but also to support future reconfiguration and change. So that will be happening in a continuous circle to enable us to deliver those efficient and effective care pathways. I think it's also fair to say that at a West Yorkshire level, which will be at a core level, they will be doing the first sort of analysis of all the population health management. So what they'll be doing is asking the places, through the place provider partnerships, to deliver and develop certain pathways. So, for example, if we see significant impact of coronary heart disease, etc., that we talked about with Mid Yorkshire Trust, they will set the ambition and the strategic direction. How we then deliver it to our local populations will be allowed to be flexible based on our population's needs, the cohorts of patients, where they're at, and how some of those patients access services. So what we will start seeing is that maybe the whole of West Yorkshire will be trying to improve coronary heart disease access and services, but we might all do it in a slightly different way because of the populations and the needs of those populations. The next slide is just giving a little bit more detail about what strategic commissioning is. So we've tried to break it down, and this is how we will be writing our future plans. So it's from using that linked patient level data, and as I've said, it'll be about identifying the cohorts, where we're getting poor outcomes, what drives some of the costs, etc., so that we're really clear on what that is, to be able to help us then knowingly make service changes and going forward, right through to navigating the politics to enable that delivery. So that is about managing our stakeholder relationships, whether that's with our local providers or with partners across the footprint, but also making sure that we can give the messaging and information back up to the centre as well as we move through it. And then in between that, there's lots of points that I've drawn out that I won't go into detail now unless you ask a specific question, but some of that is about building the capacity within our local systems and also managing our local markets. So it's not a one size fits all, even though we're striving to get a consensus regarding the outcomes that we're looking at for our populations. So the future role of the ICB moving forward, what the blueprint did tell us that was issued is that there's 3 core functions. That is the function of the strategic commissioner, the convener role, and the integrator role. So the strategic commissioner I've sort of talked about already. It's about defining those cohorts, where we're going to have the biggest impact, but also setting some of those measures and the outcomes that we want to do, and then using our data intelligently to be able to deliver that. The convener role is where the ICB works on those wider footprints, so where it brings those wider partners together across our West Yorkshire footprint and our place footprints to deliver some of those larger or bigger ambitions that we have to deliver some of those national priorities. So that'll be areas around, for example, where we are working with people who are not in work, which is not solely a health problem, but health has a significant impact on that. So it's how we can contribute to some of those wider programmes, but also then how locally we can work with housing, the police, etc., in delivering some of those services, so that we're looking at how we get the biggest impact for our population, but also managing those wider impacts and determinants of health or poor health. So it's about where we play a part in that. And then the integrator role is really about some looking at how the local ICB is going to change. So I think I've said at other meetings, and I've certainly said through Health and Wellbeing Board, etc., that we're in the midst of a massive change on behalf of the ICBs, and the ICB has got to reduce its workforce by 50%. So it will become a much smaller entity moving forward, which is why we'll be focusing on these 3 key roles. Within that, we will have across CKW, Leeds and Bradford what we call the integrator teams. The integrator teams will work and be that place-facing, I suppose, resource that we've got to build those relationships up. So one of the things that we need to be mindful of is that we'll be building the relationships up with our local authorities, our health and wellbeing boards, our local overview and scrutiny committees, but also with providers that will be delivering this service, whether they're statutory providers or other partners within this. And that will be about co-designing our future models of care to meet those national asks. So I've said about how the integrator functions will work. Of those 3 integrator functions, there will be an element of that has got senior managers that do it once on behalf of Calderdale, Kirklees and Wakefield. But underneath that, there will be teams, and my language is probably clumsy, but it will be the people that are actually doing the work. I'm really leading and out there with the practices and the neighbourhood teams to make the changes linked into the acute trusts, etc. And what we've tried to do within the model is give some, I suppose, sovereignty to place and subsidiarity. We're recognising in there that there are small teams that will be Kirklees facing or Wakefield facing, so that those relationships can really get established to take things forward. There are other elements within the reorganisation that will be managed. So there are some clinical and professional arrangements, such as managing medicines optimisation, all age continuing care, that again will work on a hub and spoke type model. So to ensure that we are delivering consistently for West Yorkshire, meeting the required standards, etc., that we need, they will have a single management structure. However, they will be place-facing, so that those relationships to our local populations will be developed and maintained. On there, I've put some high-level numbers for you. So the future ICB at West Yorkshire is going to be moving from circa 1,200 people to 600 people, and that's whole-time equivalent, sorry, so there might be more people with flexible workers, part-timers, but that is a 50% reduction. So one of the things that we've undertaken prior to Christmas was a first round of voluntary redundancies, and there is a second round that is currently ongoing, and we're looking to see if anybody else might want redundancy. And we're running that at the same time as we are out with consultation on what the proposed structures look like. The structures will probably change to some degree once we've completed consultation, because we'll have to be mindful of the feedback and views that come in. So there will be, all the information will be deliberated before the final ICB structures are signed off and published. And the anticipated date for that is the mid to late March, so that recruitment can take place starting from April through to June, which means then the last people exiting the organisation will probably leave about September time. I think it's fair to say that it will be a massive change. We will see a significant change in the workforce, and there are a number of risks that we have identified. But within that, some of them are about things like business memory, corporate memory, expertise of workforce, etc. What I've put on slide 8, just so that you're cited on it, is there is obviously a transitional phase to move from what we have now to what the future model will look like, both locally for the ICB, but also at a national level once the DHSE and the NHSE changes take place, and they change their functions as well. And as this happens, there are a number of things that will be seen as core ICB functions, but there will be still some services that need to transfer to other parts of the NHS. So we've talked briefly, and I'm going to talk a little bit more about the integrator functions, but at some point over the future 12 months, the next 12 months, the expectation is that they will move out of the ICB, and the staff will TUPE transfer into the place provider partnership arrangements once they're established, but I'll cover that more as we come on to it. Slide 9 is just showing what some of the core functions are and the capabilities that we believe, and where you can see the different colours on this slide, it's where we are expecting that there will still be some movement of that staff and that workforce, that they won't remain necessarily functions of the ICB. Though, as I said at the beginning, for example, the Green Plan and Sustainability will be sitting with the ICB for the next 12 months as a minimum, because we were notified that future plans have not been agreed yet for things like that. So there is some work that we will be continuing to work on. Slide 10 just shows you what the end state functions are expected to be, so as we move through that transition, and they're the elements that we've talked about. What you can see is some things are going to be on a much reduced scale. So, for example, organisational development and HR functions will be greatly reduced. So that then brings me on to the place provider partnerships for Kirklees. So one of the key things, as I've said, that has to move at place is that there is an expectation that each place will have a place provider partnership established, and they will take on, in the long term, the responsibility for the provision and the commissioning of out-of-hospital care. Stroke community care. So we try not to talk too much about it just being community care, because people start picturing that as the community services we've got now. So that's the reason we're using the out of hospital, because it allows us to develop things further, and it isn't then just NHS hospital provisions. One of the things that this will do by having the place provider partnerships is putting the autonomy into the places. And they will receive the resources or the biggest amount of resources to be able to deliver those functions that they are commissioned to deliver. So what I think is important to know is that from April 27, this will be done through a formal contracting arrangement with those place provider partnerships from West Yorkshire ICB. So it will lay out very clearly the expectations that they have of the place provider partnerships, what they want delivering, though it won't be prescriptive about how it's delivered, but what they want delivering. The aim is that from April we will hopefully have a shadow partnership arrangement in place for the 5 places. So I've already talked about that the integrator function will be on a Calderdale, Kirklees, Wakefield footprint, and then Leeds and Bradford. What we have recognised is within that, as I said, that we're working a hub and spoke type model because we've got to deliver to the places. And what we are really mindful of is that we have got different local authorities. So Kirklees, so if I just refer to it as CKW, we all recognise that is not a place, it's not an entity. So we're being asked to deliver and try and work on that footprint. but we have still got the relationships and the populations locally that we need to address. So the place provider partnership for Kirklees will be that entity that's looking to deliver out of hospital care for the Kirklees population. As I've said, we're aiming to have a shadow format, or the partners are aiming to have a shadow format to be able to do that from April 26. Over the next financial year, there'll be a lot of work done to ensure that the governance is robust and sound, and there is an assurance framework that has to be worked through before any formal contracts are handed over, and B, that the provider partnerships accept that they get that delegated authority. So they want to do their due diligence, that there's enough resource in the system, and they're getting the right budget allocations to be able to do that. So in Kirklees, we've been working at some pace to try and get ready for this, and especially given it was only in November when we were told that the foot had come off the pedal again, and the redundancies, etc., were all going to be taking place. I think before that we'd reported that there was a pause in the system because redundancy funding hadn't been identified by the centre. When they did identify that in November, basically we were told we had to do that within this financial year. So we have been now moving at pace around this work. So what we have aimed to do for the place provider partnership and the work that has been taking place is that we don't want to throw the baby out with the bathwater. We've already got absolutely really good working relationships with partners across our footprint already, and we worked really effectively and efficiently together. We've got a strong health and wellbeing board plan that had a health chapter within it. We were already doing the work on our neighbourhood health, which was aligned to that. So we've very much said what is in there that is really good that we want to retain, and how can we make sure that the new entity of the place provider partnership is building its vision and strategic direction around those big strategies that we've already agreed to and we've signed off. So I don't want anybody thinking this is something totally brand new and we've thrown everything out, because we certainly haven't, and we're working really closely with all our partners. And I can see that Councillor Addy is on the call, and Councillor Addy has me at the Health and Wellbeing Board regularly to give the updates and give the assurances and share the draft workings of the plans and everything to do that scrutiny over those elements. So what we have very much done is we have set a vision that does correlate, as I say, with the Health and Wellbeing Board vision and strategy. And slide 12 in your pack just tries to draw out how we have strengthened that in the work that we are doing. But there is nothing in there, I would hope, that you've never seen before, and certainly through these presentations. So some of the priorities that we're certainly working on through all of this is building on that joint working and collaboration that we've already got, as I've said, that we want to deliver good quality integrated neighbourhood health. And even though Kirklees is not one of the national pilot sites, we are very much engaged and taking learning from those pilot sites, but also sharing information back in. Because for some things we are slightly ahead, and other things we're moving at a similar pace to the rest of West Yorkshire. And as I've already said, it's that transformation of pathways outside of hospital, advocating for that shift from hospital to local communities and homes. And those priorities will continue to evolve and develop as the partnership matures, but it is building on those things we're already doing. So we've already got some priorities that we've agreed for this year, which include our end-of-life model, especially for those people in the last 12 months of end of life, ensuring people don't go to hospital if they don't need to go to hospital, that we facilitate discharges back home as quickly as possible with the right packages of care. So all those things are still in there and are still our priorities.
Sorry to interrupt you, Vicky. I am conscious of the actual time. The panel do have quite a few questions we want to ask, plus we do have Stacey's presentation on Health Watch. So if you could just sum up so that we could then get on to the questions, that would be great. Thank you.
Yeah, so I think where we've got to, and what you'll see in the next lot of slides is actually the timescales that we're working to develop the place provider partnership. As I've said, it will be shadow form from April and move hopefully by 2027 under a contracted agreement. We've included a couple of slides just to show you the governance process so that you can see that it still links back in very clearly to Health and Wellbeing Board and local governance mechanisms. And then there's just a couple of slides that are included that show some of the work that we're actually taking currently around identifying those services that we think are our out of hospital services, how we're identifying the budgets, but also developing the governance and infrastructure. Just on the governance and infrastructure before I wrap up, so that you cited, we have prepared some draft terms of reference and MOUs, and that will be going through the statutory governance routes of the partners for them to have sight of between now and the end of March. I'll leave it there, Chair.
Thank you. Before I open up for questions from the panel, Councillor Smage would like to ask some questions, and she does have another engagement to go to.
Thank you so much. Thank you. I've actually got some questions. Vicky, we appreciate you working under very difficult circumstances. You know, we appreciate that. But I would like to know about the governance information for the Shadow Provider Partnership. Where is that? Can we see it? Scrutiny really should have eyes on this. Have all the partners signed up to the partnership? What is the decision-making process that needs to take place for that Shadow Partnership to go into place? And why is Kirkwood Hospice not part of the partnership as a full member? Why is that?
So,
yeah, go on.
I'm going to say, in fact, can I answer some of the questions first?
Yeah.
So, the governance arrangements are being worked on as a West Yorkshire level, so it's the central governance team. My understanding is that the draft terms of reference, MOUs, gosh, I lost my words then, didn't I? Are ready to be circulated with all our partners. So they've been in development sessions while they've been getting, I'm going to say, thrashed about on what will be included. So all partners have been in those development sessions. There's now a format in a draft version that is ready to circulate to share with all our partners. And we're just pulling some comms together to support that so they don't land cold, if that makes sense, to be able to share with people. Your question about have all providers signed up to it. So all providers are sat round the table. So certainly for the Kirklees element, all the chief execs of all our statutory organisations are around the table. And then through the ICB Partnership Board, which still is the statutory body as we are now, we have done development sessions and workshops with all our other partners. So that includes representatives from Health Watch, so Stacey's been part of that. It includes our VCSC, it includes our GPs, etc. And we're starting to do the rounds with those partners as well to bring them on board and how they're fully engaged. Whether somebody is a full member or in attendance is very much down to where the accountabilities will sit for the monetary values. So Kirkwood Hospice are by no means excluded from any of this. They will be a partner, just like they are on the Kirklees ICB board now. But it's about the statutory responsibility, whether you'll see them down as a formal member or as in attendance. I think what is fair to say from a Kirklees perspective, this is getting refined all the time. We do want our key partners, but what we also are recognising is that the subcommittees, the subgroups underneath the partnership will be where the work is done, and they are getting focused around very specific, I want to say, themes. So for example, and I will use the hospice as an example, it's not always not always appropriate. It's not always a good use of the hospice's time or their representatives to sit in everything that's relating to acutes and things. But where we're doing all of our end of life dying well, they are the key partner, and they need to be in there and leading that piece of work. So what we're trying to do is make sure we can maximise people's capacity and efficiency and not have them sat in 100 meetings that they don't need to be in, but making sure those voices are heard very clearly. As guidance comes out from the centre, so an example of this is public health. What we have identified is that public health have been taken off of the West Yorkshire board membership. So we have picked that up. So what you're seeing is things at a point in time that when the slides were prepared for this meeting. But what we've done is we identified that when we were all sat in the meeting at West Yorkshire Partnership, and we have now, as Kirklees said, we're going to put a place in our local arrangements for public health so that their voice gets fed upwards. So we're constantly re-evaluating that as we move forward.
Okay, so can you tell me when you're talking about moving up? So will the place partnership itself be a decision-making body in its own right, or will there be other decision-making bodies that it needs to go to?
Both. So what will happen? So what will happen is that West Yorkshire ICB will set the commissioning intentions. The totality of the money will sit there first. They will then delegate the budget through a contract to the place, and then the place will have some decision-making abilities, responsibilities within that devolved budget.
Right, okay. This is why I think we need to see the governance. Scrutiny needs to see where all these layers come in, where all the decisions are being made. I mean, one of my concerns is that if there are decisions about end-of-life care, that the hospices get their share, get their voice, etc. in there, and it's not drowned out by larger partners.
Yes.
And there's no conflicts of interest and things like this.
So I think it's fair to say on the partnership, just on that, if you think about the way the current partnership works through the ICB, we've used the terms of reference and we've said where we've already got processes for dealing with conflicts and things, we want to make sure they're built into the new one. We don't lose that.
Okay. All right. I'm taking up too much time, but I just can't. I think a scrutiny,
but as soon as we get it,
needs to be involved in those discussions about those terms of reference, because I think getting that right at the start is a key thing to this. But thank you so much, Councillor Lawson, for giving me an opportunity to ask my questions, and I really now have to go. Thank you.
Thank you, Councillor Smage. If I can just go back to some specific things in the presentation, you mentioned that the development of the Kirklees Provider Partnership is led by a design group. Who exactly is on this design group?
Oh, right. So the design group, you're testing me now. The design group is made up of representation from all our key partners. So we've got local authorities, we've got the acute trust, we've got the community providers, we've got voluntary sector representatives on there. It's made up from representatives from the current Kirklees ICB partnership.
Thank you. What involvement has Kirklees Council had in setting up the new structures and the governance of them? You also mention a memorandum of understanding for place partnership providers. Has this been shared with Kirklees Council, and what input has Kirklees Council had in drawing up this memorandum of understanding?
Yeah. So yes, the council have been involved. Like I've just said for Councillor Smage's question, it has been led by the West Yorkshire Core Governance team, and through the partnership arrangements there. So Steve Mawson, for example, has been actively involved, as have members of his teams and services at differing levels as that work has been worked through. So, for example, at times he's played a governance leading. At other times it's been people like Michelle Cross that have played a part in the design group. So at all points people have been engaged. As I said, the governance team who've been doing this piece of work have just finalised the draft versions to come back in, and my understanding is it will go into all partners because it needs to go through their arrangements to check that they're happy with the proposed terms of reference, and I believe it will go in through your executive corporate team in that route to get out to people within the local authority.
When is it likely that the memorandum of understanding will actually be shared with Kirklees? Because looking through your presentation, there obviously are clear points where you're aiming for it all to be signed off by partnership organisations.
Yes, so my understanding is that they're actually looking at disseminating or sharing it out this week. It's just waiting for the comms to be tidied up, but yeah, they're aiming this week. It might even have landed, if I'm perfectly honest, because they don't keep us fully informed if they've done it, but the aim is this week.
Thank you. Helen, did you have a question?
I did, and well, I've got several questions. It's more of a comment really, that this is a huge piece of work, a huge area that is hugely significant to Kirklees, and I am really conscious of not rushing through it. But I'm also equally conscious that we've got a really important piece of work to listen to about Health Watch and its future, and I'm just really disappointed that this is the first time we're hearing this. And there is so much detail in here that we don't have the answers to, that I kind of feel like it needs something separate to this, because it's a huge piece of work that personally I've only just seen, and there is still a lot of detail not there, and I could ask 10 questions about detail that, you know, are not going to be the best use of this time now.
So, I mean, I'm happy for you to send the questions in, and I'll answer them as best I can. I think it's fair to say that this has been moving at pace. We have been engaging where we can. My understanding, and I don't know actually, I might have to ask you this question. West Yorkshire, because West Yorkshire ICB is the overall entity, we're just the place element of that. And my understanding is that people like Anthony Keeley and Ian Holmes, Rob Webster, have been engaging with the wider partnership and doing various presentations. What I don't know is if they've actually been to the West Yorkshire overview and scrutiny to do that. And that is maybe a question that I need to ask as well.
I was going to say, just to answer that question, I'm told that they haven't actually been to the West Yorkshire scrutiny.
Right, I can raise that tomorrow if you like. There's what West Yorkshire call an organisational change group meeting tomorrow, and I can certainly raise that and ask the questions. A, do they intend to, and B, can they get it on their plan to be able to do that? Because there's a lot of the work that we're doing. So, for example, the terms of reference, etc., have to be mirrored to the West Yorkshire Board and the changes that are taking place at West Yorkshire Governance Board, given that we're just an entity of that board. So we need to make sure that the whole thing is linked together. So I can certainly raise that if that is helpful, Chair, tomorrow.
Thank you for that, Vicky. Councillor Zaman.
I've got a couple of questions, but I was also wanting to make a comment that I am quite disappointed that Health Watch is going to be integrated into this formal sort of organisation, and how independent is it going to be? So my question is, what formal mechanisms will exist for this panel and for Health Watch Kirklees to be notified of and influence major commissioning changes proposed by the new ICB? Will there be clear escalation routes, and if feedback And how will it sort of respond if feedback is overridden?
So I think there's two things in that point. The changes to Health Watch are not of our making, they are national requirements that Health Watch will be abolished, and I know Stacey will come on to that. What we have recognised, not only at Kirklees but also at West Yorkshire level, is that the voice of the public and our citizens is crucial in developing, not only in developing services but getting feedback on services. And we are all having discussions collectively and with Health Watch about how we believe we can maintain, or we will maintain, that independence. We've agreed, so myself and Mark Brooks have met with Stacey, and we've agreed on behalf of Kirklees. Across Kirklees we are doing a mapping exercise. So one of the things that we are trying to do now is map all the different levels of engagement and involvement that we have as separate providers, but as a collective, to see where that independence is, where the gaps are, so that we know what we would want to commission for the future. I think it's fair to say, it probably won't be with Health Watch, because I think they'll probably end up being a different entity in their own rights as well. But we do recognise the importance of that independence, so we will be looking at how we do that, whoever that new entity is.
Thank you. Councillor Donovan, is it a quick question?
It's to ask that I think we need to seek to bring this back at a later date. I've got a number of questions, clearly other members and of the committee have got a number of questions as well. I think we'd be doing a disservice if we didn't do that, knowing that it's 10 minutes from the meeting finish time and we've yet to hear from Health Watch. I think if there's scope to do that and the members are happy to do that, I think we should seek to do that. Thanks, Chair.
That was actually going to be my suggestion, because there is a lot of questions that we've actually got. We also want to be able to hear Stacey's presentation on Health Watch. So is what we would like to do, Vicky, is to obviously invite you back so that we can have a fuller discussion on the governance model there, and especially how it's actually going to be scrutinised when there are plus now and in the actual future.
Yeah, and I'll say yes to that, and I think what I will do is I'll certainly raise that within the Place Provider Partnership Design Group and Working Group, because I think the future partners and the people that are going to be leading this need to be involved. From April, we won't be. I'm going to say we won't be. We won't be a Kirklees ICB anymore. So we'll just have to work out who comes to present that to you.
We would actually hope that it was actually done sooner than actual April. If need be, we could actually set up sort of an additional scrutiny panel to actually look at that, because there are a number of issues that we would have liked to have actually raised. Obviously, we're mindful that we've actually got 3 different items on this committee meeting. Obviously, I tried to give an hour for each sort of subject and hope that we could have done the ICB Health Watch as they were linked within that hour.
Yeah, I mean, by all means, do your invite. The only thing it will be who will be representing, given that there's 50% of our workforce leaving. I'm not saying I'm going, but my role will change as part of this, because they have taken my role out of the structure, the future structure.
Thank you for that, Vicky. We will obviously get the invite and the actual remit of what we would actually like to be discussed at that meeting to you, and we can put some suggested dates, probably within sort of the next 4 weeks, I would have hoped. But thank you for attending.
Thank you.
If I can then move on to the presentation on Health Watch.
Okay. Thank you, Chair. Mine isn't as complicated as what you've seen previously, so I'll be as quick as I possibly can. So the NHS 10-year plan has said that there is an intention to abolish the National Health Watch England body and also the Health Watch network. Functions related to capturing patient voice are likely to transfer into the local authority and also into the ICB or the place provider partnerships moving forward. We're expected that those changes will happen from March 2027 onwards. So for a little bit for people who don't know what Health Watch do, we have statutory powers to enter and view any health or care service. So that means that we can go and view services and talk to patients. We don't actually use that power in Kirklees or in Calderdale. We actually do that on a partnership basis. We know that when we work with services, we get much better outcomes for people. But we truly do listen to local people's experiences, not just about health and care, but about holistic things, housing, safety, things like that. We run projects and we gather feedback. It's also about championing patients' voices on a much wider scale. So we work in all of the structures that we've heard about today, but we also work on a West Yorkshire level as well. So we are involved right down to frontline, all the way up to these big, huge organisations that we've been talking about today. And we sit at every single level of that. We are a team of 9 across Kirklees and Calderdale. We work at capacity all of the time. And what we have expertise in, not only talking to people who are seldom heard, but also making sure that data and recommendations are in front of the right people to make sure that change happens. I've put a lot of risks on here, and we know that people are fearful of talking directly to providers of services because they think it will impact their care. There's probably just 2 things, because I want to give you a chance to ask some questions. This will be the first time in 50 years the independent voice is not captured, and the thought is that it would be captured by other entities moving forward. That feels really disappointing. And the second thing that I want to flag is, yes, we know that providers and other organisations across the system collect their own patient feedback. Actually, that gives us a really fragmented view of the service and health and social care as a whole. Health Watch is the only organisation that is currently a statutory body who can also have a look at that whole system approach and be involved in conversations around how we're going to commission services moving forward, but also ensure that patient voice are involved in that. So yeah, those are the 2 main things that I wanted to flag. We are in talks with, obviously, Kirklees and Calderdale, ICBs and local authorities. But what I will say is that we are a charity that hold to Health Watch contracts. We still want to continue the work around independent voice. We are currently looking at other funding options for us. We have other contracts already as a charity. They aren't enough to sustain the Health Watch work, but it will mean that we can maintain an element of that. And that we aren't going away as a charity. We are going to try and continue. So I'll pause there just because I know there's probably questions, but it's just to say we aren't going anywhere. You know, if there is an opportunity for us to influence what we've been talking about for the rest of today, we will still continue to do that. And hopefully we've had a meeting with the Department of Health and Social Care this morning, who have confirmed that local authorities and place provider partnerships moving forward will be funded and have the opportunity to contract out to an independent voice organisation if they wish to. So that confirmation coming today is really actually quite positive for us. So we'll see how that pans out. And people, you know, systems may decide to want to do it themselves moving forward, and we can play an element in that. But actually, I hope that there's lots of places all over England that say actually this needs to be independent. Thank you.
Thank you for that. Thank you for that, Stacey. As somebody who has actually been at meetings where Health Watch have come down to very marginalised communities to get their actual actual opinions. I can see the work on the ground. I also reiterate the fact that people are reluctant to complain about to the organisation that's provided their care and could be providing it. Again, they are more likely to come to you to actually to voice those concerns, which could be done sort of anonymously. And that is one thing is getting people through. I also feel that is to me, is when you're looking at how well a service functions, don't get the person running the service to actually do that. I was once asked to get feedback from my patients, and I says, well, it's all going to be positive. And they looked, and I says, well, they're hardly going to say to me, actually, the care provided was substandard, whereas they might have said that if somebody independently was done there. Can I open it up to questions from the panel? Ellen.
Thank you. I was just going to say that my concerns are exactly as you've written as the risks, and just to echo what the chair has just said, that I think because there's a vacuum from the ICB as to what will be in its place, when it would appear, from all evidence that what Health Watch does and has done works, and that's news now that you've told us that they could actually contract with you to do it. But yet we've just heard earlier in the meeting that it was almost like a definite Health Watch won't get the contract. So it's really, I would have hoped that's not the way that sort of information was.
So just to confirm, in terms of what I've said about the Department of Social Care, Health and Social Care this morning, Health Watch will no longer exist as an entity moving forward from April 2027 if legislation is signed off. What will still survive are charities like myself who hold 2 Health Watch contracts, who are still delivering independent patient voice, but it's actually down, Health Watch won't exist, so they won't be able to be commissioned moving forward. But I think there are still elements of, there are lots of us across the country who are still continuing, and actually we will continue badged as something else, delivering independent voice. Those could be commissioned if places choose to do so.
I was just going to say, and I hope that is the case and that it functions as well, and you've got all the right resources to do that. It's really important.
Yeah.
Councillor Monroe.
Thank you, Chair. I'd just like to say I was really sickened to read this report, and I completely agree with what my colleague here has actually raised and what you said in your report. But I just wondered, if legislation is signed off and your status changes to just charitable status, will your voice on behalf of patients, families, and everybody else carry the same weight?
No, is the question. So we will not be a statutory body moving forward. The statutory responsibility for collecting patient voice would sit with ICBs and local authorities. I think that over the last 13 years, well, in fact, over the last 50 years, I'm hoping that there is enough weight behind patient voice now, and being sat in the right rooms, having the right conversations is enough to ensure that that we are taken seriously, but we would lose those powers, yes.
Sorry, Chair, if I can. So if I've understood that, what you're saying is that it will be the ICB and local authorities to voice the view, to be the voice of patients. Is that what you're saying? That would carry weight?
They would have the responsibility and accountability for collecting patient voice, and we would be a standalone charity.
Thank you very much. Thank you.
Are there any further questions or comments the panel wants to make? With regards to the presentation from Health Watch, the committee notes the concerns that have been raised regarding the changes post-2027 and the repercussions that this may be felt by our residents when some of the work Health Watch does is incorporated into NHS or statutory bodies. We sincerely hope that alternative funding can be found for the vital work Health Watch does within our communities to continue. And thank you for coming to give your presentation. Regarding the presentation for the ICB, the committee notes that the work that has been done in remodelling the functions currently carried out with the ICB, and the ambition for there to be a period of shadow committees working alongside the existing ICB in the run-up to April 2027. We note that information will be shared and presented to Kirklees Health and Wellbeing Board, but scrutiny needs to be part of any government's model. I would like to therefore invite an ICB representative to attend another scrutiny committee prior to the new system going live for a fuller look into how the government's model will work and how decisions will be scrutinised. We'll just move on to the actual last item on the agenda, which is the actual work programme. The next meeting is on the 4th of March. Is there any other business?
Yes, Chair, I was just going to make a suggestion in terms of the item that we had about these changes to the ICB, NHS and Integrated Care Board, the Health Watch, etc. Whether it would be appropriate for us to meet quite quickly as a panel, just informally to start with, to understand some of that governance things a bit more clearly, and then invite the partner of the ICB back to answer questions. So I would suggest a fairly quick meeting for us to have a look, particularly at the fact that the risks and the accountability of a lot of things seem to be shifting to the local authority, and that absolutely does need some form of scrutiny in terms of the governance. So are we content if I suggest a set-up of a meeting fairly quickly, just informally, for you to meet together, to get together a brief and scope for then the ICB to come back again, I would say quite quickly, to another meeting?
Right. If there's no other questions, I'll close the meeting and thank you for all attending.